It's a real pleasure to be part of this great session and to give you a quick overview of gene therapy for inherited retinal diseases. I have no personal financial interest in any of the work that I'll show you today. Let's start by considering a fairly typical patient with an inherited eye disease. He's a 14-year-old male who was born completely deaf, but because he received bilateral cochlear implants in the first few years of life, he developed completely normal speech. He has good visual acuity, but for the past few years he's noticed some difficulty with night vision. Goldmann perimetry reveals fairly normal responses to the largest and brightest stimulus, but the 1,2E and 1,4E isopters are pretty noticeably constricted. Fundus examination reveals a blonde fundus with healthy discs, slightly constricted vasculature, and some bone spicule-like pigmentation in the mid-periphery. The combination of profound deafness at birth and retinitis pigmentosa early in the second decade of life suggests the diagnosis of type 1 Usher syndrome. Fortunately, inexpensive genetic testing for Usher syndrome is available and reveals the patient to have the two most common mutations in USH1C, the second most common gene associated with type 1 Usher syndrome. In this case, the family was able to afford the genetic test, but if they had not been able to, we could have turned to a philanthropic program called Project Usher for financial help in getting this family tested. So we have a 14-year-old male with molecularly proven Usher syndrome who still has good acuity and pretty good visual fields. If this were your son, what would you want? Well, what I would want is some type of therapy. A type of therapy that could prevent progression of his disease from where he is now to where his more severely affected family member is. I would want my friend Steve Russell to put about 300 microliters of clinical grade virus carrying a normal version of the USH1C gene into the subretinal space of one eye. I'd want him to put it in the part of the retina that was destined to lose vision the soonest and that would be least likely to cause significant harm if the treatment was unexpectedly toxic. Then I would want to follow my son for a few years comparing the visual field and OCT of the treated retina to the mirror image region of the fellow eye as a control. Wanting all this and knowing that some genes have been in human clinical trials since 2007 and that the preliminary results from some of them have been promising, I would visit two websites, clinicaltrials.gov and the American Society of Gene and Cell Therapy, to see if there was an USH1C trial that's currently recruiting patients. If you conducted such a search today, you would find that to date, only 7 retinal genes are being or have been evaluated as gene therapy for human retinal disease. Unfortunately for our patient, USH1C is not on the list. How often is it the case in 2016 that we can identify the disease-causing gene in a family but not have a treatment trial to offer them? To answer this question, we recently studied 1,000 consecutive families diagnosed with Mendelian retinal disease in my inherited eye disease clinic at the University of Iowa. We were able to identify disease-causing genotypes in 76% of the families for an average cost of $1,200 per family. The 760 genotypes we discovered in this cohort were distributed among 104 different genes. Some of the genes are much rarer than others. 92 of the genes each cause disease in less than 1% of the cohort, and USH1C was one of these. The main message that I'd like to convey to you today is that all the basic laboratory and surgical technology that we'll need to treat the majority of inherited retinal diseases already exists. We just need to find a way to deploy this technology at a lower cost and in a higher throughput manner than we have been doing. If you own your own manufacturing facility, you can manufacture clinical grade AAV for about $1,500 per patient. We built the DESI facility at the University of Iowa to manufacture clinical grade virus and transplantable retinal cells in a completely nonprofit fashion. And if anyone is interested in building a similar facility, our blueprints, instrument lists, protocols, and standard operating procedures are all freely available. There's a limited amount of money in our healthcare system, so the lower we can get the cost of these treatments, the more people we will be able to treat. By manufacturing them in a nonprofit academic setting, we can dramatically decrease costs and get more of these clinical trials underway in a time frame that will be relevant to the patients we're seeing today.